Hello everyone, welcome back to the series of lectures in pulmonology. Today we'll be discussing about pulmonary hypertension. So, what is pulmonary hypertension? We have learned about systemic hypertension, right? So, whenever there is an increase in the resistance to the flow of blood from the LV to the aorta, you can have systemic hypertension. Similarly, whenever there is an increased resistance in the pulmonary vasculature, which includes the pulmonary artery and the pulmonary veins, there can be an overload in the right side of the heart, predominantly the RV and the RA, and this is what we call as pulmonary hypertension. Okay, so pulmonary hypertension, as per definition, it is defined as a heterogeneous disease involving remodeling of the pulmonary vasculature, which leads to increased resistance within the pulmonary vessels. So the most common causes when you look at for pulmonary hypertension, it is most often secondary to a chronic left heart disease or due to an underlying pulmonary disorder, right? So any problem with the lungs or any problem with the left side of the heart can result in pulmonary hypertension as well. So whenever there is development of pulmonary hypertension, which side of the heart is predominantly affected? It is the right side. So the RA and the RV are the most common chambers which are affected. Okay, so pulmonary arterial hypertension, PAH, is a subtype of pulmonary hypertension, and this is characterized by pulmonary arterial pressure more than 25 millimeters of mercury. In the latest definitions, this cutoff has been reduced to 20 millimeters of mercury. Okay, so pulmonary arterial hypertension is a subtype of pulmonary hypertension where you have the pressures in the pulmonary arteries to more than 20 millimeters of mercury. Okay, so clear? So what is pulmonary hypertension? There is a heterogeneous disorder which involves the remodeling of the pulmonary vasculature, leading to increased resistance within the pulmonary vessels. Two most important causes that you have to remember is a left heart disease and an underlying lung pathology. And which are the chambers which are affected as a result of it? It is predominantly the right-sided chambers, the RA and the RV. Okay, clear? Now let us look at the pathobiology of pulmonary hypertension, right? So we have two models which have been proposed, which includes the plexogenic model and finally resulting in a vasoconstriction. So now let us look at the cross section of the pulmonary artery. So when you see the cross section of the pulmonary artery, you have the endothelial cells here. Then these are the smooth muscles which is denoted in yellow. And these are the pericytes. So you have endothelial cells, smooth muscles as well as the pericytes. Okay. So over the course of time, whenever there is an increased resistance to the flow of blood within the pulmonary vessels, apart from the resistance, there can also be stimulation of fibrotic factors, growth factors, antioxidant mediated injury, defective metabolism. So all of this can result in remodeling. Okay, so whenever there is defect in the metabolism or defect in the autoregulation, there is a defect between the different types of growth factors. Because of this increased resistance, there can be remodeling. Okay, so how does this remodeling happen? As you can see in this diagram, there is increase in the smooth muscles which are surrounding the pulmonary artery. So there is increase in the smooth muscles. Apart from that, the one that is denoted in red, there is increased deposition of elastin. There is increased deposition of elastin. Okay, so there is smooth muscle hyperproliferation. There can be increased deposition of elastin because of mismatch in the growth factor regulation. Apart from that, over the course of time, you can see these markings in blue are nothing but inflammatory cells. They are inflammatory cells. Apart from that, you can also have formation of certain channels within the smooth muscles which are called as endothelial channels. These are called as endothelial channels. And as the smooth muscle cells and the fibroblasts begin to proliferate, they encroach within the lumen of the pulmonary artery. And can you see that the lumen which was so big has become so small? So you can see that they encroach within the lumen and cause narrowing of the pulmonary artery. So finally, ultimately, there can be a narrowing of the pulmonary artery. And this is what we call as the plexogenic model, which explains the pathophysiology of pulmonary hypertension. So once there is narrowing, what happens to the resistance? So once there is narrowing, there is an increased resistance to the flow of blood. There is increased resistance to the flow of blood, and hence there is development of pulmonary hypertension. Alright, so because of a dysregulated metabolism, dysregulated apoptosis pathways, dysregulation in your growth factors, right? So all of these basically result in your smooth muscle proliferation, encroachment into the lumen of the pulmonary artery, increased inflammation, finally resulting in increased resistance. Also, there is another model which is proposed, which is called as vasoconstriction. So, there can be certain stimuli where there is an imbalance between your vasodilatory and your vasoconstricting molecules, ultimately resulting in increased vasoconstricting molecules, which results in narrowing of the lumen of the pulmonary artery, resulting in pulmonary hypertension. Okay, fine. So, both plexogenetic model as well as your vasoconstriction models explain the pathophysiology of pulmonary hypertension. Okay, so what happens as a result of the increased resistance? So whenever there is an increased resistance within the pulmonary artery, right? So what happens to the pressure within the pulmonary artery? The pulmonary artery pressures are going to increase, and this is what we call as pulmonary arterial hypertension or PAH. So this is what we call as the pulmonary arterial hypertension or PAH. Now, once there is a pressure within the pulmonary artery, these pressures are going to get reflected into which chamber of the heart? It is going to get reflected into the right ventricle. Like I told you, the right side of the heart is going to get affected the most. Now, if there is going to be increased RV pressures over the course of time, the RV will not be able to compensate for this increased pressures. Similar to how in systemic hypertension, your LV cannot compensate beyond a particular point of time. So, the RV goes into failure because of fibrosis, because of dilatation, because of pressure overload, because of dilatation over the course of time. It can undergo fibrosis and goes into RV failure. Also, the RV pressures will also be reflected onto what? It will be reflected onto the right atrium. So, the RA as well as the RV pressures will be LV. Now, if the RV goes into failure, what will happen? If the RV goes into failure, there will be stimulation of the renin-angiotensin-aldosterone system, because we had learnt in our heart failure chapter as well, whenever there is heart failure, there is stimulation of the renin-angiotensin-aldosterone system. Now we know that the renin-angiotensin-aldosterone system is basically going to recognize the volume condition in our body. So this is going to recognize that there is not adequate pumping. This is going to recognize that our body is not in volume sufficient state. Hence, chronic stimulation of the renin-angiotensin-aldosterone system is going to cause salt and water retention. Okay, so this is going to cause salt and water retention. Alright, this is going to cause salt and water retention, and that is the reason why chronic right heart failure presents with anasarca. You would have learnt this, right? So, chronic right heart failure presents with anasarca. It presents with pedal edema, abdominal distension. You can have tender hepatomegaly and raised JVP, and this is the reason for that. And over the course of time, chronic stimulation of the renin-angiotensin-aldosterone system is going to result in chronic kidney disease as well. Okay, clear? So, this is about the pathophysiology of pulmonary hypertension. Pulmonary hypertension is going to cause a backward pressure, increased pressures in the RV as well as the RV. Over the course of time, it results in RV failure. Once there is RV failure, there can be chronic stimulation of the RAS system resulting in anasarca, and you can also have CKD. But that is in a very, very chronic time. Before that itself, they become symptomatic. Okay. Now, this entire process where there is RV failure. Okay. So, RV failure secondary to underlying lung pathology. So, whenever there is an RV failure secondary to underlying lung pathology, this is what we call as cor pulmonale. This is what we call as cor pulmonale. Okay, so you've understood the pathophysiology of cor pulmonale as well. So, this is very clear. Now let us move on. Let us understand what are the genetic and molecular determinants of pulmonary hypertension. So the first is that there can be alterations in the regulation of proliferators. That is the reason why you have abnormal smooth muscle and fibroblast proliferation that we have seen in your plexogenic model. Okay, so there can be alterations in the regulators of the proliferators like growth factors like transforming growth factor, vascular endothelial growth factor, and your bone morphogenetic protein. BMP is your bone morphogenetic protein. So many of these factors are altered in your secondary forms of pulmonary hypertension and also in your idiopathic forms of pulmonary hypertension. Okay, there can be alteration in the transcription factors as well. Second, there can be alteration in the mediators of fibrosis. Okay, so what are those proteins that you should be knowing? They are NET9, galactin-3, PDL1. Now, why should we be aware of all these factors? The reason being, in the current era, we are finding molecules which can act on these molecules, right? So, we are finding inhibitors of these molecules, and hence the therapeutic treatment of pulmonary hypertension can change. That is the reason why we should know about the pathobiology to this depth. Okay. Then there can be alteration in the inflammatory mediators resulting in abnormal inflammation of the pulmonary vasculature. Then there can be changes in the vascular tone, right? So that is the reason why there is vasoconstriction. So there is an imbalance in the vasodilatory and the vasoconstricting molecules, alteration in the vascular tone. So endothelin, nitric oxide, calcium and potassium ion channel defects, all of these can result in abnormal vasoconstriction. Okay. Then genetic factors which contribute to pulmonary hypertension, which includes SMAD9, SOX17, aquaporin 1 molecule and BMP receptor defects, all of these can result in pulmonary hypertension. Okay, so there can be alteration in the regulation of proliferators, alteration in the mediators of fibrosis, alteration in inflammatory mediators, alteration in the molecules which are associated with the vascular tone, and genetic factors. Clear? Now, we will be looking at this particular slide again, but before we move on to the clinical features and so on, let us understand how the treatment of pulmonary hypertension is changing. Okay, so there are certain targets which we have identified for the effective treatment of pulmonary hypertension. Okay, so there are three pathways that we should know which are involved in the pathobiology, and we are targeting exactly these three pathways to improve the quality of life in pulmonary hypertension. So the first pathway is your endothelin pathway, second pathway is your nitric oxide cyclic GMP pathway, and the third pathway is your prostacyclin pathway. Okay, so these are the three major pathways which we should be aware of because we have therapeutic targets to these three pathways currently. Okay, so first, proendothelin is converted into endothelin. Okay, and endothelin is predominantly involved in the vasoconstriction via the endothelin A and the endothelin B receptors. Okay, so proendothelin is converted into endothelin, and endothelin is responsible for vasoconstriction via the endothelin A and endothelin B receptors. Okay, so if you give endothelin blockers, endothelin inhibitors, right? So endothelin inhibitors form one of the first line managements for the treatment of pulmonary hypertension. So one of the first line targets in the treatment of pulmonary hypertension is your endothelin receptor blockers. Which are those? We will be looking when we look at the management. Next, nitric oxide cyclic GMP pathway. Now, L-arginine is converted into nitric oxide, and we know that nitric oxide has a vasodilatory effect, right? Nitric oxide has a vasodilatory effect, and this acts via PDE5 and it acts via soluble guanylate cyclase. Okay, so nitric oxide has vasodilatory effects. Hence, so we give stimulators of PDE5, which is your phosphodiesterase 5, or soluble guanylate cyclase. So if you give stimulators of these pathway, you can cause vasodilatation and thereby help in reducing the resistance in pulmonary hypertension. Okay, so this is the second most important pathway that we should be known. Third is your prostacyclin pathway. Now, how is prostacyclin formed? arachidonic acid is converted into prostacyclin, which acts via CAMP, and which is your cyclic adenosine monophosphate, and this also helps in vasodilatation. Hence, we give prostacyclin analogs in the treatment of pulmonary hypertension. Okay, got it? So, we give endothelin receptor blockers, we give stimulators of guanylate cyclase, or we give phosphodiesterase 5 stimulators, or we give prostacyclin stimulators or prostacyclin analogs, which help in vasodilatation and reducing the vasoconstriction. Okay, so this is the basics by which the various drugs are developed in the treatment of pulmonary hypertension. Alright, clear till here. Now let us move on to the WHO classification of pulmonary hypertension. Okay, so we have 5 grades. Okay, so group 1 is pulmonary artery hypertension or PAH. So what are the group of disorders which come under group 1? So this includes heritable causes. We had seen a lot of genetic factors, right, in the development of PAH. So all forms of heritable or idiopathic or genetic cause of PAH is group 1 PAH. Then drug or toxin mediated PAH, then HIV associated pulmonary hypertension, then we have CKD associated pulmonary hypertension, then connective tissue disorders. What are the connective tissue disorders? Including your scleroderma associated pulmonary hypertension, then your pulmonary veno-occlusive disease or PVOD in association with pulmonary artery hypertension are all part of group 1 PAH. So group 1 PAH, remember, heritable, drugs, toxin, HIV associated and connective tissue associated are the amongst the common causes that we see in your group 1 PAH. Then group 2 PAH is pulmonary hypertension due to left heart disease, comes under the category of group 2 pulmonary hypertension. So what are the causes of left heart disease? Heart failure with reduced as well as heart failure with preserved ejection fraction, then valvular heart disease. Okay, so all of these come under group 2 pulmonary artery hypertension. Then group 3 pulmonary hypertension is pulmonary hypertension due to lung disorders, due to an underlying lung disease like COPD, restrictive lung diseases, obstructive sleep apnea and obesity hypoventilation syndrome, high altitude related pulmonary hypertension. All of these are group 3. So pulmonary hypertension due to underlying lung disease is your group 3. Group 4 is chronic thromboembolic. Okay, so group 4 is chronic thromboembolic hypertension. That means what? So whenever you have a pulmonary thromboembolism, there is an embolus which goes and lodges itself in the pulmonary artery, right? So when it is an acute or a massive embolus, the patient is extremely symptomatic, right? They come with acute onset dyspnea, they can come with acute onset collapse. But sometimes there can be pulmonary thromboemboli which are smaller in size and get lodged in the pulmonary artery, and they do not become symptomatic for a long time, and once they become symptomatic, they present similar to that of pulmonary hypertension itself. They present with long-standing dyspnea, long-standing right heart failure, and this type of pulmonary hypertension is called as your group 4 or your chronic thromboembolic pulmonary hypertension. Group 5 is the rarer group secondary to hematologic malignancies like your myelodysplastic syndromes, metabolic conditions like your Gaucher's disease, glycogen storage disorders. Sarcoidosis, remember sarcoidosis, though it is part of a connective tissue disorder, it comes under group 5. Okay, then we have the sickle cell anemia related pulmonary hypertension, and PLHC is pulmonary Langerhans cell histiocytosis. Okay, so remember hematologic malignancies, sickle cell anemia, storage disorders, sarcoidosis, PLHC, all these are group 5. Okay, so this is about the WHO classification of pulmonary hypertension. Group 1 is PAH, Group 2 is due to left heart disease, Group 3 is due to lung disease, Group 4 is chronic thromboembolic type of pulmonary hypertension, and Group 5 is your rarer disorders. Alright, fine. Now let us look at the hemodynamic classification of pulmonary hypertension. Okay, so how do you measure the pulmonary pressures, right? So how do you measure that? We measure that using what we call as the right heart catheter, right? So you measure that using what we call as the right heart catheterization. Fine. So what do we do in this right heart catheterization, right? So we basically try and measure the pulmonary pressures. So you take, just like how you do a catheterization using the Seldinger's technique for your coronary angiography, similarly you take a catheter and you pass it along the guide wire and you measure it via the RA, via the RV, then you go to the pulmonary arteries and then you go to the capillaries and measure the pressures at each level. Okay, so once you insert the catheter, the first chamber where you measure the pressure is your right atrial pressure. So the normal right atrial pressures are between 0 and 6 millimeters of mercury. Then you push the catheter down forwards into the right ventricle and via the right ventricle you go to the pulmonary artery. Okay, clear till here? Now once you move into the pulmonary artery, the pressure that you obtain there is your pulmonary arterial pressure, and this is what is about 10 to 20 millimeters of mercury. So when the pressure in the pulmonary artery is more than 20 millimeters of mercury, that is what we call as pulmonary arterial hypertension. Now the pulmonary artery breaks down into multiple capillaries and goes into the lungs. Okay, so the pressure that we measure in the pulmonary artery before it breaks down into capillaries is called as the precapillary pulmonary artery, right? So this is what we call as the precapillary pressures. Okay, now once you move ahead in the pulmonary artery and reach the capillary, we go up to a point where the catheter cannot move any further. So we move up to a point where the catheter cannot move any further, and this is what we call as the pulmonary capillary wedge pressure. That is, the catheter is wedged within the capillary. So this is what we call as the pulmonary capillary wedge pressure, which is about 4 to 15 millimeters of mercury. Okay, so what are we looking at? We are looking at how do you measure the pulmonary artery pressures using the right heart catheterization. So you measure the right atrial pressure, right ventricular pressures, pulmonary arterial pressures and pulmonary capillary wedge pressure. Okay, then after the capillaries, whatever it breaks down into is the post capillary pressures. Fine. Okay, so now based on these measurements, we have the hemodynamic classification of pulmonary hypertension. So the mean pulmonary artery pressure more than 20 millimeters of mercury is your pulmonary artery hypertension. This definition we already know. Okay, once that you have obtained, you basically look at the pulmonary arterial wedge pressure, right? So this is the pulmonary arterial wedge pressure. And what is the pulmonary arterial wedge pressure basically indicative of? It is indicative of your left ventricular end diastolic pressure. What is the meaning of that? So basically the LV pressures will be back reflected to the LA pressures, and these LA pressures are back reflected into the pulmonary pressures. So the pulmonary capillary wedge pressures is basically equal to your left ventricular end diastolic pressures, provided there is no problem with the LA or the pulmonary artery, right? So the pulmonary arterial wedge pressure is representative of the LV end diastolic pressures. Okay, so based on the pulmonary artery wedge pressure, you can divide the pulmonary hypertension into pre-capillary and post-capillary types. So in pre-capillary pulmonary hypertension, the pulmonary artery wedge pressure is less than 15. It is not going to be affected. So any cause of pulmonary hypertension up to this point, right? So pulmonary arterial pressure or pulmonary hypertension due to any other problems up to the pre-capillary portion is the pulmonary artery wedge pressure will be less than 15. If the pulmonary capillary wedge pressure is more than 15, what does it indicate? The pulmonary artery wedge pressure is a representative of the LV end diastolic pressures. So if the PCWP is increased, the LV end diastolic pressures is increased, which means that it is a problem with the LV or a problem with the heart. So this means that directly it is a group 2 pulmonary hypertension or pulmonary hypertension due to left heart disease. Okay, fine. So this also means that this is a post-capillary hypertension. Now in your post-capillary hypertension, what we have to see is that we look at the pulmonary vascular resistance. So pulmonary vascular resistance basically denotes the afterload on the RV, correct? So the RV is pumping into the pulmonary artery. So if there is increased resistance in the pulmonary artery, then this is the afterload to the RV. So we see the pulmonary vascular resistance, which is the afterload to the RV. And this is given by the formula transpulmonary gradient. This is given by the formula transpulmonary gradient by the cardiac output. Okay, transpulmonary gradient by the cardiac output. So how do you obtain the transpulmonary gradient? It is the mean pulmonary artery pressure minus the pulmonary artery wedge pressure, which is the transpulmonary gradient. So you can see that this pressure minus this pressure. Okay, let me use another color for this so you will understand this better. So the pressure that we obtain here, let us say, is A, and the pressure that we obtain here is your pulmonary capillary wedge pressure, which is B, right? So here versus this wedge pressure, because it is encountering a resistance, correct? Because the diameter of the vessels are narrowing, it is becoming capillaries. So the pulmonary arterial pressure minus the pulmonary capillary wedge pressure is your transpulmonary gradient. Okay, so this is your transpulmonary gradient. So transpulmonary gradient by cardiac output is going to give us your resistance. It is going to give us the resistance to the flow of blood. Clear? So whenever you are looking at post-capillary pulmonary hypertension, you can also have to look at the pulmonary vascular resistance, which is given by the transpulmonary gradient by cardiac output. So if this value, pulmonary vascular resistance, is more than 3 Wood units, it is a pre-capillary plus post-capillary or a combined pulmonary artery hypertension. Okay, so if the resistance is more than 3 Wood units, then this is a pre-capillary or a combined pulmonary hypertension. If it is less than 3 Wood units, if the resistance is low, then it is an isolated post-capillary only. Okay, it is an isolated post-capillary pulmonary hypertension only. Okay, fine. So this might seem a little bit confusing. Let us just revise this once more. So once you have diagnosed pulmonary hypertension, you are going to divide it into pre-capillary versus post-capillary based on the pulmonary artery wedge pressure, right? So if the pulmonary artery wedge pressure is less than 15, then it is due to a cause up till here. So it is a pre-capillary pulmonary hypertension. If it is more than 15, then it is a post-capillary pulmonary hypertension. Post-capillary means what? Basically any cause which is causing pulmonary hypertension above the or after the capillaries. After the capillaries means predominantly your left side of the heart. So your LV-EDP rises, LA pressure rises, then your post-capillary hypertension is going to be predominant. Now, once this is done, you have to see the pulmonary vascular resistance, which is given by the formula transpulmonary gradient by cardiac output. What is the transpulmonary gradient? It is your pulmonary arterial pressure minus the pulmonary capillary wedge pressure. So this difference by cardiac output is going to give us the resistance. So if the resistance is increased, it means that it's either pre-capillary or a combined cause. If the resistance is not high, then it is an isolated post-capillary. Isolated post-capillary means like predominantly your left heart disease. Okay, clear? So this is your hemodynamic classification of pulmonary hypertension. Now let us understand the clinical features of pulmonary hypertension one by one. So what are the symptoms with which they are going to present? So patients with pulmonary hypertension are going to present with long-standing dyspnea predominantly on exertion, right? They can also have bendopnea. Bendopnea means dyspnea on bending forwards, which is a characteristic sign of heart failure, right? So we had learnt it in left heart failure, even in pulmonary hypertension because of increased afterload to the right heart, you can have bendopnea. Then they will have exercise intolerance. Over the course of time, what will happen to the RV? The RV undergoes dilatation because of pressure overload. And then once the RV dilates, you can have palpitations. Palpitations because of volume overload. RV dilatation, then the RV is not contracting well. So in order to improve the cardiac output, the RV is going to contract at a faster rate and you can have palpitations. Apart from that, you can have hemoptysis. And once the RV goes into failure, you will have anasarca or edema. They can have non-specific chest pain and pre-syncopal episodes as well. Now let us look at the signs. So what happens to the JVP? What happens to the JVP whenever there is an RA-RV pressure overload? There will be an raise in the A wave. Okay, so there will be a raise in the A wave, right? So the A wave becomes more prominent in your JVP. Okay, in chronic stages, in chronic pulmonary hypertension, you can have cyanosis as well. Okay, fine. Now, on auscultation, what are you going to find? So, what happens to the P2? The P2 is basically the second component or the pulmonary component of your second heart sound, right? So, what happens to the P2? The P2 is going to be loud. The P2 is going to be loud. And what happens to the split of the second heart sound? You are going to have a narrow split. You're going to have a narrow split. Which murmur do you hear in pulmonary hypertension? So, over the course of time in chronic pulmonary hypertension, the murmur that you're going to hear because of RA-RV dilatation, it is your tricuspid regurgitation murmur. So, tricuspid regurgitation means what? A pansystolic murmur in the tricuspid area. So, pansystolic murmur in the tricuspid area which increases on inspiration because it is a right-sided murmur, right? So, a tricuspid regurgitation murmur will be heard. Now, if the patient has gone to the stage where there is development of a TR murmur, then what wave becomes prominent in your JVP? It is the C wave. It is the C wave. And this prominent C wave is what we call as the Lanz-Sissy sign. And this prominent C wave is what we call as the Lanz-Sissy sign. So, there can be development of a TR murmur, there can be development of prominent C waves on the JVP. Okay. So, this C wave can combine with the V wave and this is what we call as the CV wave. Okay, the C wave can combine with the V wave and you can have prominent CV wave as well. So, in the initial stages in the JVP, you will find prominent A wave. In the later stages, you can find your prominent CV wave or the Lanz-Sissy sign. Apart from that, you can have loud P2, you can have narrow split P2, you can have TR murmurs as well. Alright. Then, in your respiratory system examination, what are the things you may find? So, whenever there is pulmonary hypertension, it can be due to an underlying lung defect, right? So, underlying lung defects, you can find evidence of emphysema. You can find evidence of emphysema. If this is due to a secondary chronic obstructive lung disease, then you can hear wheeze as well. You can find crepitations, which are Velcro crepitations. Velcro crepitations in cases of interstitial lung diseases resulting in secondary pulmonary hypertension. Okay. Then per abdomen examination, if there is development of cor pulmonale and RV failure, you can have tender hepatomegaly. And tricuspid regurgitation is a common cause for pulsatile liver. You can have pulsatile liver and you can have ascites as well. Okay, fine. So, CTD associated interstitial lung diseases can be associated with clubbing and hence if you find clubbing, it is also pointing out to the underlying cause for pulmonary hypertension. Similarly, in your congenital heart disease resulting in pulmonary hypertension, even then you can have clubbing, right? Then you look for other features of other connective system disorders like sarcoidosis. Sarcoidosis can have skin manifestations. The skin manifestations of sarcoidosis are called as lupus pernio, which basically points towards sarcoid. Similarly, if you have a scleroderma related ILD, what are the skin manifestations? You can find thickening of skin, you can find calcinosis, which is basically subcutaneous deposition of calcium, right? Then myositis related ILDs, what will you find? In dermatomyositis, you find your Gottron's papules. You can find your Gottron's papules. Okay, you can find your Gottron's papules. So, this is about how different systems are involved in your pulmonary hypertension. So, whenever you get a case of pulmonary hypertension, please do a head-to-toe examination because it can help in pointing out the cause for your pulmonary hypertension. Alright, clear? So, this is about the various clinical features. Now, so what are the tests that we use to diagnose pulmonary hypertension? So, the first test is the ECG. So what are the findings that you would expect on the ECG? Which part of the heart, which chamber of the heart is going to be most affected in pulmonary hypertension? It is going to be the right side of the heart. So RA-RB dilatation will result in what type of changes? It will result in a right axis deviation. It will result in a right axis deviation and an RV strain pattern. What is the meaning of RV strain pattern? There is ST depression, T wave inversions in which leads? In the leads V1, V2 and V3. Also, you will have prominent R waves. You will have prominent R waves in V1, V2 and V3. And what about the P wave changes? P wave basically represents the atrium, right? It represents the depolarization of the atrium. So whenever there is a right atrial enlargement, what type of P wave you will find? You will find P pulmonale. P pulmonale basically refers to the peaked P waves which are more than 2.5 centimeters in 2.5 small boxes in height. Okay. So can you see here the QRS complex is negative in lead V1 and positive in AVF, indicating right axis deviation. Can you see in the ECG prominent R waves in your septal leads, and you see ST segment depression, T wave inversion in your septal leads, indicative of RV strain pattern. Clear? Fine. Then second, what do you find on your chest X-ray? So in your chest X-ray, you find pulmonary arterial dilatation. So the pulmonary artery is dilated. Then you have RA enlargement and peripheral pruning of vessels. Okay. So when you take the X-ray in a lateral view, you can see that the retrosternal portion is abutted because of the enlarged RA. Alright. Fine. Now let us look at what do you see on the 2D echo. The 2D echo, you can see evidence of RA-RV dilatation. Now if the RA and RV are dilated, then the LV becomes very small, and this type of an LV, because of the septal bulge into the left atrium, is called as a D-shaped LV. You can have a D-shaped LV. Also, whenever there is pulmonary hypertension, the pressures from the right ventricle are carried backwards into the IVC. So the IVC diameter increases and there is IVC plethora. And you can find evidence of tricuspid regurgitation as well. Okay. So these are the echo findings in pulmonary hypertension. Then the next test that we do is something called as vasoreactivity testing. What do we do in this vasoreactivity testing? We give IV iloprost. So we give IV iloprost. Iloprost is basically a prostacyclin analog. We have learnt that prostacyclins are basically drugs which help in vasodilatation. So what is the aim of giving this iloprost? The moment you give iloprost, these vessels undergo vasodilatation. Now once they undergo vasodilatation, it means that they are still not in your remodeling phase and they are responsive to this vasodilatation drugs. So this indicates that this group of hypertension can be treated with the help of calcium channel blockers. So the whole aim of this vasoreactive testing is that you identify the group of patients who will be responsive to calcium channel blockers. So moment you inject iloprost, a positive test is denoted by a mean pulmonary artery pressure which decreases by 10 millimeters of mercury to an absolute value of less than 40 millimeters of mercury. Okay. So which group of disorders are vasoreactive testing positive? They are your idiopathic PAH, your heritable PAH and your drug-induced PAH, which is basically your group 1 WHO classification. Okay. So this is about your vasoreactive testing. The next test that you can do is the pulmonary function testing. So if only the diffusion of lung to carbon monoxide, which is your DLCO, is reduced, this indicates that this is basically due to a vascular pathology, maybe because secondary to a pulmonary thromboembolism. If the DLCO is reduced and along with that the FEV1 by FVC ratio is increased, then it's probably due to a lung pathology like a restrictive lung disease. Okay. So this is about the various tests which can be used for the diagnosis of pulmonary hypertension. Now apart from this, there can be other tests which can be done, which includes the HIV testing to identify whether this is HIV related, anti-SCL70 which helps in the additional diagnosis of scleroderma. Then you can use BNP, which is your brain natriuretic peptide, which also acts as a prognostic marker and indicates the level at which the RV failure is, if the RV failure has set in or not. Then CTPA or VQ scan, when will you do? This is used to find out pulmonary thromboembolism. Right? So CTPA is used to find out pulmonary thromboembolism, and the additional study, you can do a sleep study to see if this is because of OHS or OSA related pulmonary hypertension. So these are the other auxiliary tests which we'll use to find out the cause for your pulmonary hypertension, right? So let us look at the flow chart. So first is that if you suspect PAH, you look at the symptoms, you look at the ECG, you look at the echo. Then your predominant focus should be on the left heart and lung disease. You assess for risk factors if this is because of a left heart disorder, is this because of a lung disease. You do a PFT, DLCO, chest X-ray, HRCT, ABG. So whenever you do the diagnosis of pulmonary hypertension, especially after the advent of the echocardiography, you do not have to right away jump into a right heart catheterization. Only after finding out all these causes, you have still not found any cause, then you may require a right heart catheterization. So in the right heart catheterization, if you find that the pulmonary artery pressure is more than 20 millimeters of mercury and the pulmonary vascular resistance is more than 3 Wood units, okay, then the only condition where the pulmonary artery wedge pressure is more than 15 is in a post-capillary form of pulmonary hypertension, where you have pulmonary hypertension due to left heart disease, right? So this is very, very important. In all the other conditions, the pulmonary artery wedge pressure is less than 15, right? So we had discussed this in your hemodynamic classification of pH as well. So if you do not find any cause, then it is a group 1. Now, if you find evidence of obstructive parenchymal lung disease, then this is a group 3, WHO group 3. Then, if there is abnormal pulmonary angiography or VQ scan abnormality, then it is because of a thromboembolism. Then, if there are comorbidities that increase the risk of PAH, like your sickle cell anemia, malignancies, then it is a group 5. Okay, so the only condition where your pulmonary artery wedge pressure or the pulmonary capillary wedge pressure more than 15 is your disorders due to left heart. Okay, fine. So this is about the approach to pulmonary hypertension. Now let us move on to the management. Okay, so which are the drugs? The drugs are classified into various groups. We have already looked at the pathophysiology and the targets as well. So first is your calcium channel blockers. Which calcium channel blockers are used? Amlodipine and nifedipine. So amlodipine and nifedipine are the calcium channel blockers used. So if you do a vasoreactive testing using an IV iloprost and it is positive, then that means that these group of pulmonary hypertension, you can use calcium channel blockers. Fine. Then you have PDE5 stimulators and cyclic GMP stimulators. We had already looked at how these drugs are useful. Okay. So these basically act on your cyclic GMP pathway. They act on your cyclic GMP pathway. So PDE5 stimulators, sildenafil and tadalafil, right? Okay, and the cGMP stimulator drug which is used, a newer drug called riociguat. Then we give prostacyclin analogs because of their vasodilatory property. The oral prostacyclin analog is selexipag. Inhaled ones we have iloprost and tipprostenil. IV is your ipoprostenol. So you should know which is oral, which is IV, which is inhaled. So oral is selexipag. Then we have inhaled iloprost, IV iprostenol. Okay. Then cGMP stimulator riociguat we have already seen. Then we have endothelin receptor blockers because endothelin is responsible for vasoconstriction. So you give endothelin receptor blockers like your ambrisentan, bosentan and macitentan. What we commonly use are basically combination drugs, which is your ambrisentan plus tadalafil combination. So what we use is the ambrisentan and tadalafil combination drug is commonly used so that two pathways can be targeted. Okay. Now, apart from this, if the patient is presenting to you in florid right ventricular failure or cor pulmonale, you may have to give them supplementary oxygen therapy. You may have to diurese them as well. But the amount of diuretics that you use is of a smaller dose. Okay. Right. Then also anemia can worsen the pulmonary hypertension and hence you have to ensure that the hemoglobin is maintained at approximately 10 gram per deciliter. So how do you approach? So first you do the vasoreactive testing. If the vasoreactive testing is positive, then these candidates can receive treatment with calcium channel blockers. Okay. Now, if the vasoreactive testing is negative, then you do a risk assessment. High risk groups, you do an IV combination therapy. In low risk groups, you do an oral combination therapy. So, in high risk groups, you do a IV combination therapy. In low risk groups, you give a oral combination therapy. If there is no improvement for both the groups, you also consider a triple therapy. So, most commonly what we use is ambrisentan and tadalafil, which are both available orally. So, we do a triple therapy, you get a target from another drug and combine it together. Okay. So, this is about how you approach and manage patients with pulmonary hypertension. So, what all have we learned? We have learned about what is pulmonary hypertension, what are the causes, what is the WHO classification, what is the hemodynamic classification, and we have looked at vasoreactive testing, the different groups of drugs, and how do you approach the case. Thank you.